Welcome to Learning Pathology with Dr. Bhavana Grandhi. Today we'll see about nephritic syndrome. Nephritic syndrome consists of hematuria, oliguria, mild proteinuria along with mild edema. It is acute onset. The primary causes are acute proliferative glomerulonephritis, post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, IgA nephropathy, and hereditary nephritis like Alport syndrome. The secondary causes like SLE, Goodpasture syndrome, polyarteritis nodosa, and venous granulomatosis. Coming to the prototype, acute proliferative glomerulonephritis seen in children caused by streptococcal infection, group A, beta hemolytic type. Usually the renal symptoms occurs after a duration of 1 to 4 weeks. Post-streptococcal glomerulonephritis, we see diffuse proliferation of the glomerular cells, pathogenesis. SPE toxin will be liberated by the bacteria, group A beta hemolytic streptococci. In the diagram, we can see the exotoxin liberated by the bacteria for which the antibodies are produced. Now the antibodies and antigens form an immune complex which is deposited at the glomeruli. The same has been represented in a flowchart. Grossly, the kidney is enlarged with external surface showing you petechial hemorrhages. Microscopy, the image on the left side is the normal glomeruli. The right side image shows the glomeruli which are hypercellular. There is proliferation of the endothelial cell, mesangial cells along with neutrophilic collection because of the bacterial infection. There is uniform increase in the cellularity. Under the electron microscopy, you can see subepithelial deposits. This is the immunofluorescence showing you granular deposits of IgG, IgA and C3. Finally, this is the overall view of post-streptococcal glomerulonephritis. Gross showing you petechial hemorrhages. Microscopy, light microscopy will show you hypercellular glomeruli. Electron microscopy will show you subepithelial deposits called as humps. Finally, immunofluorescence, there is granular deposits of IgG, IgA and C3. The post-streptococcal glomerulonephritis, the light microscopy features, electron microscopy and immunofluorescence features. The clinical case, pharyngitis, the patient complains with pharyngitis and eczema. Young child coming to the clinic with a history of malaise, fever, and there is a duration of 1 to 2 weeks after the onset of the pharyngitis and the renal symptoms. So proper clinical history taking, complete urine examination and serology is very important for the diagnosis. This is the panel of serology, all the antibodies which have to be tested for the final diagnosis. Progression of disease in children, usually 90%, eventually good recovery is seen. Whereas in adults, only 60% recover well, others go to chronic proliferative glomerulonephritis. The non-streptococcal causes of acute glomerulonephritis are staphylococcal, viral like hepatitis B and C, and parasitic infestations like malaria and toxoplasmosis. These are the characteristic immune complexes seen in non-infectious type of glomerulonephritis. The second entity which we are discussing today is rapidly progressive glomerulonephritis, or also called as crescentic type of glomerulonephritis, where crescents are the characteristic feature. This is the classical histological picture showing the formation of crescent. We have three types: type 1, type 2, type 3. Type 1 is anti-GBM, where the antibody is against the glomerular basement membrane. Type 2, immune complex mediated, and type 3, pauci-immune, where immune complexes are less. This is the classification. Type 1, good pasture is the prototype. Type 2, IgA nephropathy, Henox choline purpura. Type 3, Vigenous granulomatosis. Coming to the type 1, antibodies are formed against the glomerular basement membrane. There is deposition of IgG and complement. This is the flow chart showing the type 1, where you have antibodies against the collagen of the glomerular basement membrane, leading to antibody formation. Good pasture syndrome depicting the kidney and the lung involvement. Immune complex mediated, or the type 2, where you have antigen antibody formation and deposition of the immune complexes. Pauci-immune, there is no deposition of the immune complexes. It is usually ANCA positive, anti-neutrophil cytoplasmic antibody. It can be cytoplasmic or perinuclear. This is the flow chart of the type 3 type. Grossly, the kidneys are enlarged but pale, so it is a cause of large white kidney. Cut surface will show you cortex. There is deposition of the immune complexes depending upon the type, whether it is type 1, type 2 or type 3. This is the crescent formation showing you the epithelial proliferation followed by mesangial proliferation along with endothelial proliferation. This is a microscopy of the crescent formation. The electron microscopy, which will show you subepithelial deposits. Immunofluorescence of type 1, which is linear, type 2 granular, type 3 little or absent. Clinically, hematuria is seen along with lung symptoms in good pasture syndrome. Next disease which we are discussing today is IgA nephropathy, which is called as Berger's disease, where there is deposition of IgA in the glomerulus. Normal individual, the IgA is present in a monomeric form, whereas in these patients it is present in a polymeric form. So this gets deposited in the glomerulus, against which IgG antibodies are formed. So these abnormal IgA has glycosylation of the end tail, leading to the proliferation and deposition in the glomerulus. Morphology, any range of glomerulonephritis will be seen: membranoproliferative, mesangioproliferative or crescentic glomerulonephritis. So this is the IgA nephropathy, where there is IgA deposition in the immunofluorescence. So mesangial deposition of IgA along with complement components also are seen. Clinically, older children and younger adults are affected. Thank you.